Thank you all for joining us. So we wanted to get together today to talk about how can the system work together to make sure that we are ready to deliver the long-term plan in urgent and emergency care. If I start with taking some opening remarks and introductions with you, James.
Okay, so I'm James Ray. I'm a A&E consultant in Oxford and also regional lead for UEC in London. But I'm also responsible for developing the IUC data set. And I suppose it brings me to the subject of standards. So I'd like to, when we get talk about clinical standards within each episode of care that occurs across the whole of urgent and emergency care.
Maureen, you said.
Good morning. Yes, just good morning, everyone. I'm Maureen Baker and I'm chair of the Professional Record Standards Body, so I'm the answer to your prayers. So, in case you don't know, PRSB, we create record standards, and the rationale for standards is to improve safety and quality of health and care. And the aim is for the right information to be available for the right care in the right place at the right time. Everybody wants that. And standards help ensure that the information is recorded correctly and can be accessed easily. PRSB, Professional Record Standards Body, is a small organisation, but our members represent 750,000 health and care professionals. So all the medical royal colleges, the main clinical and professional bodies across health and care, with patient voices, regulators and other relevant organisations all represented in PRSB. This agenda is so important in urgent and emergency care. Clearly, people turn up at all different parts of the NHS and they're often not limited service. And in urgent and emergency care, clearly, there may be situations that are potentially life-threatening or life-changing, and clinical decisions have to be made quickly. Access to high-quality information made a huge difference to the outcome of the patient, and the information on that care episode also needs to be available to the next professional down the line, whether that's in the hospital, another hospital, general practice. Now, 6 months ago, PRSB published information sharing requirements for integrated urgent care, and these will serve as the basis for further work to develop, pilot and deploy the integrated urgent care data sets as part of a system-wide approach. If I've got time, very quickly, I'll just give you an example. I've recently worked as a GP in the emergency department. In this particular setting, I get handed notes from the emergency department on paper. I then go into another room, it's actually in the emergency department, but not of the emergency department, and I look up that patient on the clinical assessment service, which is not available to colleagues in the emergency department. And if I then sometimes do decide that that patient actually needs to go back into the emergency department, because that's right physical care, I have to give that information back to them on paper. I mean, that is just not a safe system, it's not a quality system, it's an error-provoking system. These are the things that lead to mistakes and to problems and inefficiencies that we all need to see an end to. So basically, PRSB, we see ourselves as bridges between the technologists, the clinicians, the professionals, the patients, and I hope you'll think that we've got an important role to play here.
Absolutely, Maureen. I know James has been wanting to talk about the IUC data set as well. I'll come back to you, James, on that. David, how, as a supplier, are you? What's on the horizon? What do you see on the horizon?
Well, this morning's been really incredibly pleasing to hear around the open standards and how we're approaching. And I just wanted to give an overview of our journey and how I feel that that's part of the system we're supporting. Some of you may know that we're a large station enterprise. We're providing integrated urgent care within the east and south east of England. clear. And I think the nuance aspect of that is that we approach this from a very much a frontline service provision basis. Clinicians, non-clinical staff, operational colleagues are involved in the journey and very much in delivery of what we do. But that's also taken us to the point where we've been able to work collaboratively with NHS Digital. Alpha design and development programs, as well as the beta testing of applications before they are introduced into the urgent emergency care services. I think keeping in line with our social enterprise ethos, and also what we've heard this morning is about making that difference, is that we're able to inform those standards. And sometimes I think that it's great to hear that the journey that we're going to be going on, but making sure that the solutions are actually fit for purpose when they delivered to the frontline teams. An example, for instance, providing clarity to the local authorities through the Child Protection Information System. It's absolutely key to understand where the child was located, not necessarily where the CAS was providing that care. Electronic prescribing in our extension and directory of services to provide an urgent care perspective, to making sure that we can search for the open pharmacies, not the one that's nominated in the GP practice system, and also 111 online, our ability to traverse the multi-channel access capability to support the patient's journey and experience in providing the online assessment and moving into the clinical assessment without starting the pathway again. So I think from my take, I'm thinking about what we've been achieving, which is tremendous in the last year, is that the duet ambitions are absolutely ambitious, but they are delivering. Just a couple of weeks ago, we went to GP Connect, viewing TPE patient records, TPE System 1 patient records within our clinical system, and moving forward to direct
Alpha design and development programs, as well as the beta testing of applications before they are introduced into the urgent emergency care services. I think keeping in line with our social enterprise ethos, and also what we've heard this morning is about making that difference, is that we're able to inform those standards. And sometimes I think that it's great to hear that the journey that we're going to be going on, but making sure that the solutions are actually fit for purpose when they delivered to the frontline teams. An example, for instance, providing clarity to the local authorities through the Child Protection Information System. It's absolutely key to understand where the child was located, not necessarily where the CAS was providing that care. Electronic prescribing in our extension and directory of services to provide an urgent care perspective, to making sure that we can search for the open pharmacies, not the one that's nominated in the GP practice system, and also 111 online, our ability to traverse the multi-channel access capability to support the patient's journey and experience in providing the
UTCs and providing care hubs, and also international apps. And I think just a few years ago that would have been impossible. So reflecting on what I think the Long Term Plan project is, and also what we've heard today about the patient relationship experience, and what very much resonated this morning with Sophie's aspect is human-centered research. That's about the NHS app, how that's going to drive innovation going forward within our services, because we'll be accessing tools that will be delivered through those ambitions. If I'm a patient and accessing services at 2 a.m. or 2 p.m. or a video chat or a digital channel, I will have the same experience as 3.
And if I'm providing services as we do in integrated care, how do we know that the notifications can be delivered through that app so that the patient's getting their expectations met? I think...
Thank you. Thanks, David. Ross, to yourself, obviously we've spoken a lot about standards today, but my question particularly to you was, how are you meeting demand? Obviously a very busy service that you provide without compromising quality.
So I'd start by saying this is by far and away the hardest role I have done. And I have a huge awe of all of you for all the work that you do day in, day out, and that's clinically, technically, or managerial, because the pressures and the scrutiny and the expectation on all of us to deliver things that people think might be trivial or easy to do to a local standard in a safe, efficient way is not like anything I've experienced in 20 years doing this type of work elsewhere. So well done all of you. I've got a huge amount to learn, and I'm enjoying what this is learning from those that we've heard from already today. And it really does resonate with me, because some of the challenges we face are about getting, in my case, we're obviously the 999 ambulance service for all of London, We're also the 111 and integrated urgent care provider for North East and South East London under separate contracts. So that journey into IUC has been a voyage of discovery. Completely understanding how all those different providers and pathways that we've not really understood as an ambulance service work, how to engage with them, how to look into them, what to do when something doesn't work, how you manage the data interoperability between all these systems when actually no one's in charge. I understand why you can't direct book in somewhere. Well, this supplier for that contract with this provider over here, and then this commissioner runs this little bit in the middle, and we're sitting the other end with patients with the right experience. There's some real joint thinking that it's exciting to see what we're looking at today and how that will take that forward. But then I look in the context of, and it's really good to hear people referencing the summary care record and iPad pilot we're doing at the moment. It's 3 weeks in. And some excellent early feedback about it's already making an impact on patients who we're giving better treatment to by having access to that data. But, and there is a but, it's yet another app on the iPad for someone who's doing an emergency response to have to think about looking at in that situation. We have got terrible uptake, if I'm being brutal about it, in terms of usage of CMC. CMC is fabulous. The data in there is fabulous. I speak to as many members of our staff who do not use it as I do who will use it. We ask them to look at CMC for care plans, MyDOS to get directory of service information, JR Calc to understand the best practice of thinking right, because otherwise the quality doesn't happen. There is no point putting all the information in there if it's not done in a usable way that makes sense to the people and is accessible in the best way when they need it. So I'm hugely excited about all of this. It is hard. We're all going to have to keep thinking about how we work together to deliver it. But let's not pretend we're solving that many of the problems yet. These are baby steps towards cracking some really complex.
Having access to information, sometimes it is actually a challenge to clinicians as well, because the more access they have to information, the more accountable they are for the decisions they make. So it's not always as straightforward as, you know, I mean, Caldecott talks about the amount of information being the right amount for the decision you need to make. So that's where it comes back to Maureen in terms of what are the standards of care, what are the standards of information that we need to make decisions. So I believe that we should be able to standardise what the clinical approach is to a person with urgent needs, whether they're in the GP surgery, whether they're in the UTC, whether they're in the out-of-hours service or the type 1 ED. And we should be able to set a standard so that patients get the same kind of care, but the only difference is the setting that the care is delivered is utilised more efficiently because of the actual facilities that area has, rather than a different type of clinical care, if you see what I'm saying. So my view would be that we look at every episode of care that occurs across the whole of urgent emergency care. We see it as a patient journey. There was a lovely map earlier of patients bouncing across the system. I've got plenty of examples of that where patients will ring 111, 999, they'll get a see and treat ambulance, they'll stay at home, then they'll call someone again, and we're totally invisible to that. So that's we have blinkers on because we don't see what's really happening to the patient journey. So how do we address that? Well, the best way to address it would be to take each episode of care that occurs to a patient on that journey, to actually capture it, have an input and an output that has a standard set to it, and that that input and output can be linked to the next part of their journey. So eventually you'll be able to see the whole journey across that, what happens to that patient. So an example would be if someone rang for a chest pain problem, that they would be assessed, and if an ambulance is called to them, they can then be seen by the ambulance service. They will be given what the chief complaint is at that particular episode of care, what kind of acuity level they're dealing with, so how ill they are, what kind of setting they need to be cared in, and then finally, what is the likely diagnosis from that episode of care. Therefore, then translating that into what setting they then need to be put into. So then sent to an A&E from, say, 111, for instance. We currently don't look at any information that comes to A&E from 111, but if they send us information about what was the problem they had, what was the how serious their illness is and what the suspected diagnosis they think it could be. For instance, if someone presents with a headache and they say, well, it's a sudden worst headache I've ever had, came on like a thunderclap, then automatically the call handler or the clinician in the house will be thinking this could be a subarachnoid hemorrhage. So when they come to A&E, we already know what path they're going to be going on. So their journey doesn't have to start again. We'd have to start asking the same questions, because quality is made up of not just safety and effective care, it's also made of patient experience. And often patient experience is often the last thing that people think of. And to have to repeat yourself repeatedly, when patients come to my emergency department, they say 111 sent me, presumably you've got all the information that they sent. And you have to sort of say to them, no, actually we don't see any of that. And there's lots of reasons why that is, but we need to move away from that. We need to develop a set of standards, develop a data set. We've got the proof of concept with ECDS, which is doing well, and we need to build on that.
Brilliant, thank you. A question for all of you. What trends and technologies do you see are key to delivering urgent and emergency care services in the future? Trends and technologies.
I think for me, part of the answer to that is not to answer the question, because the trends are in understanding the user needs, whoever the user is, and finding the best answer for it. I can't recall whose slide it was earlier, it might have been Sophie's referencing. It's about the user needs, not whether it's natural language processing or AI or big data. So I'm going to answer by completely not answering your question, if that's okay.
You can take that.
From my perspective, again, I think the trends will deliver. I think some of the challenges is that I see from where I work is that there's a focus or a lack of focus from an urgent emergency care basis from maybe an STP level and from the funding aspects of that. And so in making sure that we are able to deliver the technologies that are absolutely required and to do the design developments, and we need to have that flow through.
Thank you. Maureen?
I would suggest there's a major trend, or maybe not quite yet a trend, but potentially will be, where patient stroke, citizen stroke users are empowered more to make a decision, do I need to go down this pathway or do I not? Do I need to take the step to see the GP, to call the ambulance, to go in E&E, or can I look after myself? I'll declare an interest. I'm a CMO of a health app, but there are a variety of these tools. There's apps, there's information on the web, there's emerging tools from the NHS. But it seems to me that this is a direction of travel, and frankly it's a direction of travel that the service is going to need. Yeah. Otherwise demand just grows and grows, and we haven't got the workforce, and we're never going to have the workforce to meet all the demand potentially there is out there.
Yeah, thank you. James?
Well, for me, reflecting back on what Simon said right at the beginning was, technology focusing on the clinician as well. So if I stand in my emergency department and look at the department, I see lots of clinicians on computers and patients behind in cubicles, and what the clinicians are doing is spending a long time doing the referrals to the clinics that they can do online, doing the referrals to their own department, to the assessment area, and doing the GP referrals, etc. And all the other things you have to add in is multiple clicks, multiple drop-down screens, and we don't even have access to other parts of the system, other parts of the EPR doesn't access other parts of the hospital, which sometimes is really vital. So for me, I think the benefits to the patients are huge if we can actually get it right for the clinicians using the technology.
From my point of view anyways, I think the trend from talking to you and listening to all the speakers this morning was around open standards, certainly, and you all reiterated that, and user experience, whether it be patient or whether it be clinician. Moving on to the next question, how do you think that you'll be delivering the relevant commitments in the long-term plan? Anything that springs out of mind that...
One of the interesting things for us to reflect on as an ambulance service is the commitment to getting the best start in life. As an ambulance service in London, we're involved, in fact this is only from the 999 side of things, it's probably more if you think of 111, but we're involved in over 3,000 childbirths per year, which is quite a high number actually. And they're probably not the simple cases either, because if it was simple, the mother would probably have a planned appointment or be able to make her way somewhere more appropriate than wanting to call 999. But we're in a world where we're putting maternity notes online. And that actually makes it really hard for us. There isn't the book sat in the corner of the patient's house that we can open up to understand what circumstances has that patient got, that we need to understand what's best for the mother and baby. So understanding how we can make sure we're focused not just on the obvious cases, but actually the really, really important, less obvious cases, I think is absolutely crucial. And thinking about that broader sense of patients that we get engaged with, I think will be really, really important to delivering it. So that's one part. I think the second part is about continuing the dialogue at board level. I think there's a huge amount of work has gone on to help boards recognise that digital is a thing to pay attention to. But actually, how many of them would describe what that means in a consistent way? Would understand what's coming over the horizon in 3 years' time, in 5 years' time, would understand the implications of the decisions that NHSX might make on how we commission new technology services. How many of them would understand when we're setting a new contract with commissioners and thinking about what that service change might mean, the implications for that joined up service journey and the digital tooling therein needs to be. So I think those boards are making lots of provider level decisions, making them have a regular focused discussion around the implications of digital for everything they do is absolutely critical. And I think the everything they do bit is my final point, which is some of this is about the nuts and bolts. I've spent the last 2.5 weeks going around most of London's ambulance stations getting face-to-face time with nearly 1,500 staff as part of our regular exec team roadshows. You know, the things they're complaining about, the internet is too slow, and you know what, it is too slow. The Wi-Fi, well, there is one Wi-Fi hotspot if you're in the right corner of the building. It's a bit like here, I suppose. But it's not where they need it to work. Some of the basics about just logging onto a PC, because some things they can still only do on a PC, well, that takes them 15 minutes. The 15 minutes early they turned up for, well, that's their time. They now need to be out on the road seeing a patient, or else they're going to be getting in trouble for not having got on the road. So there's some real basics we need to get right. We need boards to focus on that. We probably, as an ambulance service, invested extremely well in technology 10 years ago, had some brilliant stuff, but then it didn't move on. I've still got brilliant 10-year-old technology. I don't have technology that's fit for purpose for today, hence the need to do all the work we're doing right now. So keeping that challenge and that focus at the board level across the nuts and bolts, keeping the basic things running, continuing the investment when it's not the thing that's in vogue with the Secretary of State, and keeping working on the things that will take us forward in all sorts of aspects like maternity are things that keep me interested.
I mean, certainly Hadley spoke about infrastructure being the biscuit layer of the Banoffee pie, so it's a...
But I think Hadley, I think what I would say to Hadley is she started almost to level up. There's some real nuts and bolts that are almost below that level of infrastructure that at provider level is often hidden. But I suspect you go into most providers, or in fact commissioners, I know that my lead commissioners' technology that they're blessed with to work with us is not brilliant either, and they often get forgotten about as well.
David, from your point of view?
So we've, this last couple of years, been making a number of investments in digital rostering and also in digital communications, and I see that the ability to integrate our technologies into those different aspects to provide a seamless kind of workflow to our patients and our clinicians and users is really important. And I think from listening, and also the work that we do from integrating with the alpha test and the beta test is about making sure that no unintended consequences occur. And if we didn't have the staff, the clinical teams and the operational teams completely involved in that delivery of those technologies, we wouldn't bring them to life. We wouldn't make the transformation, which I think is touching on your point. Yep.
Maureen?
So with building from what's been said, I would say that without the clinical professional engagement The long-term plan is just a plan, it's just a document. It either sits on a bookshelf or on a cyber shelf. Without the actual buy-in of the people who are delivering the service, it is nothing. So we have to get clinical engagement in this digital agenda, we have to. And if we learn the lessons from the past, over the last 20 years, initiative after initiative has crashed and burned because the people on the front line don't think it's got anything to do with them. So it's just so critical to get this. And it's a two-way street. So the products, the services need to be designed with the user, the clinical user in mind. But the clinicians or other professionals, they also need to be much more engaged. So instead of thinking technology, that's the CIO guys, those are the techies, it's got nothing to do with me, I'm clinical. We have to move away from that completely. And it's like, if you use the analogy with education, so just about any professional, that's a paramedic, a nurse, a doctor, they're professional and they do education. They educate others, they attend events. It's part and parcel of their professional ethos. And we're not yet at the stage where tech and digital is part of the professional ethos. And that's a big step change that needs to be facilitated, but it needs to happen in order to get the engagement we need.
James, you?
So, prior to ECDS, 2% of pregnancy-related problems that turned up in A&E were in men. And we couldn't demonstrate, how can you demonstrate quality care across the whole system? And it's only since ECDS that we're actually be able to see people, what they're coming in with, what they're going out with. No longer can you go to A&E and present with a headache and go home with a headache. You've got to show some kind of added value to that service. Likewise, embedded into the 10-year plan, the long-term plan, is SDEC, which is same-day emergency care. And it's about delivering things that you would normally think of admitting someone for and treating that person, and then demonstrating that you can deliver that care quickly, effectively, without the need to disadvantage them by admitting them to a hospital. So it's not just about the easy wins, the sort of cellulitis patients, the DVTs. We don't want to. That's not SDEC. The true nature of SDEC is to demonstrate where we can actually improve quality of care for sensitive cases that are normally reasonably high acuity, such as people with pulmonary emboli, with community-acquired pneumonia, or even someone who presents to A&E with fast AF. Now we can show that we can treat these people within a day, and then follow them through so they get looked after back in the community. And and demonstrating that with data is the only way to really show that you're actually making a difference.
Thank you. A reminder to viewers who are watching us on YouTube, you can ask the panelists some questions if you wish to, using the hashtag #DUEC2019. Our team's monitoring the hashtag, so if you do have any questions for the panel, do please send them through social media. Last question from me, and we then open it up to the audience, is what do you think, actually I think I've just been reminded it's 5 more minutes. I think we'll take some audience questions. I think the question I was going to ask was what do you think were the challenges, but I think we've covered quite a bit of it. Audience questions, please. I have spared 5 minutes, so I really hope you don't let me down. And then Vishen, please.
Ross, you mentioned about the nuts and bolts and how it's just getting the basics right, like Wi-Fi and so on. And I think, Maureen, you mentioned about getting clinical engagement. We're almost caught in this between a rock and a hard place of digital immaturity, which varies across, I think, the UK and between trusts and between primary and secondary care, and trying to get that kind of clinical engagement at the same time where actually professionals are clinically kind of IT immature. So how how do you, as a group, kind of see us improving and shortening that gap between the two?
So I'm not sure I've got the perfect answer. I think it's something we're continuing to work on. I think we've worked hard in LAS to appoint a CCIO who's been in post quite some time now and is the first ambulance sector CCIO, although no others are following along, and that's helping make the engagement more relevant to clinicians. I'm the IT guy, right? I get it. I've never been clinical. I never will be clinical, and you wouldn't want me to be. So when I go and have a conversation with some of our staff about what this means for them, that doesn't always resonate. They need to have a peer that they can resonate with, someone who's got an equivalent background. So that's a core part of what I think we're trying to work on, but that can again be dependent on one person and a hero culture. I think I completely agree about the transformation of how we operate. There's a bit of language we're trying to land around how these aren't separate things, these digital tools, these are clinical tools. They happen to be a bit of IT, but actually it's part of your clinical working tool set. We're also trying to measure the investment we're making each year to understand how much of it is about keeping the basics going and how much of it is about genuinely enhancing with new things, new ideas, replacement capability, to be more conscious about that balance. That balance, I think, will need to ebb and flow from year to year based on what the priorities are. But it's not something that my organisation has historically done well enough, is guide that balance of investment, both financially but also in management time, clinician time, development time with our staff. So taking that as something that we genuinely think about is slowly helping to shift the dial.
For me, there's something about, I mean, you mentioned digital immaturity of the clinicians, and I don't quite get that, because in every other aspect of one's life, most people are digitally mature. Of course they are. And we all get anxiety attacks if we can't find our phone for 2 minutes. That is just life. Yet we go to work and, cyber desert. It's like life in the olden days. When I was a junior doctor and we'd no such thing as internet, and there would maybe be one computer in an institution. That's almost what it's like. So there needs to be. We need to be much better in the NHS at making working life, using the same sort of tools and techniques as we do in life. And one thing, and this is a plea to NHSX, stop complicating stuff. I mean, I love the NHS it's the best thing we've got in this country. But if there's a way to make something overcomplicated in the NHS, we will find it. And just to be able to harness the power and the potential of tech like we do in our lives, I think would make a huge difference. And training, forget it. It's just, here's a technique and it's like WhatsApp. Here's a technique and it's like, I don't know, Snapchat, doesn't matter. And then they're on it, that's it. So we need to get much better at that.
Thank you.
My point. I'd like to just re-emphasize the point that Maureen made about clinical leadership and engaging clinicians in this digital transformation. And my question is actually more of a statement and a question. How do we actually work across organizations, cross-representation, whether it's X, E, I, D, whether it's the colleges, whether it's policy at the BMA or RCGP or GPC? Where do we actually get that cross-party or cross-organizational agreement to actually work and engage our clinicians to take this forward? Otherwise, like you rightly said, this policy will remain on a bookshelf or in a folder, and it sounds nice today, but in 2 years' time we'll be thinking about something else. Maureen, you've been in this place before in your other roles. What do you suggest we do?
Well, that's a hard one, isn't it? So I do think that the development of NHSX is absolutely a step in the right direction. And, if we can't use this opportunity to get everyone onto the, onto the same playing field, then that's a huge opportunity lost. Again, with PRSB, all the medical royal colleges, you know, the RCN, the RCM, the pharmacists, all the HP organisations are all members of PRSB. So I would love PRSB to be more visible as a means of, you know, just helping people to come together with NHSX, with other bits of the system, so that we can, you know, we really have to work together. You're absolutely right, and it's not going to be easy, but we kind of need to have the systems in place that will, you know, let us bring that jigsaw together. Hope that helps.
Thank you. It's been an absolutely stimulating panel discussion from my point of view. I'm sure our audience has enjoyed it as well. Any closing remarks? I've been reminded we have a minute to go. 25 seconds each if you wish to take it.
So I would just simply say the key for me builds from that. The things that we've advanced the most rapidly with is where we work with others, where we try and do it on our own. That's where we fail to get it right. So make the time in your diaries to go and work with the people in your area, whether they are local or sector specific. That's what will help get things done. And if any of you would like to talk to me about what we're doing and would like to get involved, please come and find me in a break.
Any closing remarks?
So for me, any stakeholders in this room that are thinking about joining the journey along data sharing and the data set work, just to come with open hearts, open minds, and let's get it all sorted so the patient journey is visible to everyone, and work together.
Thank you. Thank you so much. I'm sure the audience will give you a farewell, suitable farewell. Thank you. Yeah, thank you. Without